engineers, ladies and gentlemen, and all my fellow doctors. As we all know here in the Indian surrounding and from our clinical practice, we Indians often have a clustering of uh, cardiovascular risk factors together. With the latest ICMR Index 17 study getting published, we know that we have more than 315 million hypertensives, 101 million projected diabetics, a greater number of pre-diabetics, uh, a good patients with obesity, visceral adiposity, and hence CV disease occurring at least a decade much earlier than that of our Caucasian brethren. Now, the heart, there's much more to talk in the heart rather than just cardiovascular disease. There's heart failure, there's arrhythmia, and there's a whole boatload of stuff that is always powerful for us to empower ourselves in our clinical practice. Today, we have an academic feast to follow with some of the best minds in the cardiology sector, nationally as well as internationally, to educate us on the latest updates from the recent HFA Congress. I have the honor of inviting our esteemed faculty and introducing the same. Just share these slides. So, as our esteemed moderator for the day, we have none other than Professor Dr. P.C. Manoria, sir, who needs no introduction as such in the field of medicine or cardiology, but I'll do the honors. He is the director of Manoria Heart and Critical Care Hospital, Bhopal, the former professor and head of Department of Cardiology at GMC Bhopal, and has served as the honorary physician to the governor of MP. He's edited various books and has more than 80 publications across various peer-reviewed journals, has been the executive president of the World Congress of Cardiometabolic Medicine, and has been awarded 7 Lifetime Achievement Awards during his career, and much, much more. We also have Dr. Gianluigi Savarese, who is the associate professor of cardiology and a senior lecturer at Karolinska Institute, Stockholm, Sweden. So Professor Savarese is currently an associate professor of cardiology and heart failure specialist at the Karolinska Institute in Stockholm, Sweden, and has served on the board of the ESC's Heart Failure Association since 2020. He's just been elected 2 days back as the secretary of the HFA, and we give him a huge congratulations for the same. Professor, it's an honor to have you. I now hand over the session without wasting any more time to our esteemed moderator for the day, Professor P.C. Manoria, sir, to set the context. Professor Manoria, over to you, sir.
At the outset, I'd like to thank the Macleods for inviting me to this wonderful session on highlights from the Heart Failure Congress Lisbon 2024. And I am delighted to be there with Dr. Sabrice, who is secretary of the Heart Failure Association. So change is the way of life. Everything in this universe changes. So also the practices for heart failure keeps on changing as new data keeps on pouring from the LBCT. In India, heart failure is reaching alarming and epidemic proportions. Currently, we have 8 to 10 million patients of heart failure. What is very distressing is 50% of heart failure patients are diabetics. Around about 20 to 20% are below the age of 30 years. The in-hospital mortality is high. The post-hospital mortality is also to the tune of 20 to 30%, and non-medical adherence and suboptimal GDMT is to the tune of 25 to 50%. So we will be very keen to have the statistics from the Portuguese population, and is there a role of gender in heart failure patients? In HFrEF, all of us know the 4 foundational drugs have kicked off a new era of drug revolution in heart failure, which never existed before. And this is a big step for improving outcome in HFrEF. Several newer devices are being tried in heart failure, and I'm sure we will have the expertise from our expert, Dr. Sabrisi, from the Relief HF trial, where an artificial intra-atrial device was used to see whether it impacts heart failure outcome, both HFrEF and HFpEF. Unlike HFrEF, which is dominated by neurohormonal activation, HFpEF is an entirely different story. And here it's not neurohormonal activation. Here it is comorbidities, obesity, diabetes, CKD, OSA, and so on. And interestingly, during the last couple of years, we have 3 positive trials with semaglutide injectable. The first 2 trials, STEP-HFpEF and STEP-HFpEF-DM, both showed that injectable semaglutide 2.4 milligram weekly improved the quality of life by KCCQ, or the 6-minute walk test. Of course, the weight reduction was reduced substantially by 10, 12, or 13%. And there was a hint that it could improve the cardiovascular outcome. The PRAISE-HFpEF DM trial showed that the outcome can also be improved by injectable semaglutide. And in recent past, we have the SELECT trial, which for the first time showed that you can improve the cardiovascular outcome in non-diabetic obesity also. So the future of semaglutide is very bright. After the drug revolution in heart failure, we have the iron revolution and several trials, the FAIR-HF, the CONFIRM-HF, the AFFECT-HF, the AFFIRM-HF, and the HeartFit have shown that in patients with HFrEF with iron deficiency, iron therapy produces improvement in the quality of life, the 6-minute walk test, and also decreases hospitalization for heart failure. But distressingly enough, the data on HFpEF is very sparse, although trials are ongoing, like the IronMet HFpEF trial and the FAIR-HF trial. In times to come, we would have data from these trials. Inflammation also plays a very important role, and in past we had the CANTOS trial, which shows very interesting finding. But now the new trial is ongoing, the Hermes trial, with monoclonal antibody against the IL-6, and we are very keen to have the results in future. Oxidative stress also plays a very important role, and the Endeavor trial is going with MPO1 inhibitors. Again, we will be very interesting to see what would be the result in future. Finerenone, all of us know, showed exciting results in the Fidelio DKD, in the Figaro DKD, and the pooled analysis Fidelity trial. But now the mono-RACR program is ongoing to redefine the role of finerenone in 4 trials. So again, we'll see future, a lot of interesting data on finerenone. Natriuretic-based diuresis has shown better decongestion, as shown by the PUTCH-HF trial. But the biggest problem in heart failure is suboptimal GDMT, which in the past was addressed by the STRONG-HF trial, and now TEAM-HF trial and TITRATE-HF trial, which I'm sure will be touched upon by our expert speaker on heart failure. And we have the elicaptan, new drug after the mevocamptan for HCM. And lastly, artificial intelligence plays a very, very important role. And now this is being tested in the Pacific Preserve trial to categorize different phenotypes of HFpEF. So I'm sure we are very keen to hear the presentation from Dr. Savarsi, and I'm sure we will enjoy the expertise of his presentations. So over to the moderator, over to the Macleods.
Thank you so much. I would like to thank you for the kind invitation. It's a great pleasure to be with you today. It's also a pleasure for me to introduce the late breaking from the Heart Failure Association. We came back a few days ago from like very large congress, which is actually the leading congress focusing on heart failure at the moment in the world. And it's my pleasure also to share my insights regarding the new evidence which has been presented during the Congress. This is the list of my disclosures. And as our estimate chairperson has already introduced heart failure as pandemic sizes. And I think that's why it's particularly important to start with an introduction of the Porto study. The Porto study is very important beyond, I would say, the evidence which is showing, just because also it really shows the efforts of a national cardiology association to try to provide good science and really try to understand the sizes of the heart failure pandemics in their own country. And this is indeed the example of the Portuguese Cardiology Society. So the Porto studies also represent one of, I would say, the most recent, and I would say the only one over the last decades to try to assess the epidemiology of heart failure in using a prospective approach. So what we know about epidemiology nowadays is mainly based on retrospective analysis of data which are collected in electronic health records, in registry, and this kind of data. But having prospective study in the community for understanding the pandemical sizes of heart failure is something extremely novel and extremely appreciable. So the Porto study had a primary objective to estimate the prevalence of heart failure among Portuguese adults aged 50 years and older. And then the secondary aims were to determine the prevalence of heart failure phenotypes according to EF. So try to understand a little bit better the distribution of PEF, MREF, and REF within the heart failure population and overall within the community. And it was also important to provide epidemiological estimates regarding distribution in terms of age and sex. And these were the primary aims of this large epidemiological study, which I can tell you will lead to many novel data and novel findings over the next years, given the huge amount of data that they collected. So first of all, in order to introduce this study, it's important to know that in order to collect good estimates about epidemiology, the investigator used a multi-stage sampling methodology to try to understand where to go with their tract. They used the tract actually to visit several places within their country and test patients for heart failure. So what they did is to use as a first approach measuring NT-proBNP in the community. So in the different towns and centers that they identify as a representative of the Portuguese population. So they went there with their track and they started to screen the population, number of patients, of course, defined according to screening strategy by NT-proBNP. So whether NT-proBNP was lower than 125, patients were defined as no heart failure, or whether these patients knew that they had heart failure, but NT-proBNP was lower than 125. And whether it was higher than 125, the next steps were actually followed. This was the stage 1, the heart failure screening approach. So let's see what happened. Whether there was no heart failure, as we saw in the previous slide, actually this proportion of the population acted as a diagnostic cohort. So it was basically the control population without any heart failure within the Porto study. Whether they have self-reported heart failure or an NT-proBNP equal or more than 125, and these cutoff are, of course, defined according to the current guidelines from the European Society of Cardiology, actually patients were further screened with an ECG and echo. It's also important to know that basically even the diagnostic cohort, so patients without heart failure, actually went through an echo and ECG. This is just to assess validity of the approach while using NT-proBNP for a diagnosis of heart failure. After ECG plus echo, it was possible to define ejection fraction. So whether patients had an EF less than 40, they were diagnosed with FREF. Whether they had EF between 40 and 50, MREF. Whether it was more than 50, the HFA PEF score was actually calculated to make diagnosis of FPEF, just because we know that the diagnosis of FPEF is difficult, and having only high NT-proBNP level is not enough, because NT-proBNP might be high because of CKD, atrial fibrillation, and other reasons. So we need some additional criteria. Whether more than 50%, let's say, whether the HFA algorithm was approached and an HFA PEF score was calculated, whether the HFA PEF score was equal or more than 5, actually there was diagnosis of FPEF, whether the HFA PEF score was between 2 and 4, actually patients were in the gray zone for the diagnosis, and therefore a TTE exercise stress test was performed to make a final diagnosis of FPEF. Whether the HFA PEF score was 1, of course, the diagnosis of heart failure was not verified. So we see here the flowchart of the number of patients who were screened, and basically starting with 4,600,000 people living in Portugal, according to the multi-stage sampling methodology. 18,000 patients were selected for the screening phase, 6,000 went through the screening phase, and you see that the confirmatory phase was performing 2,500 patients. Of these 2,500 patients, actually, those who were symptomatic were screening, so actually 2,300 patients had an EF more than 50%, around 100 patients see the differences in ejection fraction of those with heart failure. So you start to understand where we will land with the results. Like an anticipation, you understand that you will see much more FPEF than FREF. Indeed, you see that actually after applying the HFA PEF score, actually 1,000 patients out of 2,400 had heart failure with preserved ejection fraction, and this leads to this very nice summary of the epidemiology of heart failure in Portugal, showing that the overall prevalence of heart failure was around 16%, but a majority of this prevalence was explained by FPEF with 15%, and just a minority had FREF and MREF. So there might be some bias in terms of selection, but this definitely tells us that if we consider the community and not patients with an already established diagnosis of heart failure, a majority of the population with heart failure has FPEF and not FREF. Let's see some more results. So 1 out of 6 patients with like older than 50 years old live with heart failure. According to these statistics, the prevalence is actually higher in females as compared to males, explained, of course, by the higher prevalence of FPEF. And we see that 30% is explained by of the population with heart failure, basically as an age over 70 years. And this is also important when we discuss clinical inertia, and we say that older patients are less likely to be treated. But here we clearly see that the majority of patients with heart failure are older than 70 years old. And that's why we should really fight against clinical inertia and prescribe GDMT to all patients, regardless of age. Here you see with some more statistics. It's very clear that patients with FPEF were older, as we usually see in any epidemiological study. They were more likely to be female. They were more likely to be obese, to have comorbidities, and to have a lower NIA class as compared to those with MREF and REF. More information is that a majority of the population in the community doesn't know to have heart failure. 90% of patients who were screened through this very complicated process actually didn't know to have heart failure. And even if they had some symptoms and some signs, actually, nobody and never made a diagnosis of heart failure in 90% of this population. So this is extremely important, in particular if we think about a very large country, as for example, India. And the lack of diagnosis of heart failure was more frequent in women as compared to men. Let's see quality of life, because what is really great regarding this study is that they collected a biobank, they collected quality of life in all these patients, and they will have soon outcomes as well. And they will be able to follow, for example, the implementation of GDMT in REF and of course also in PEF. Such as, for example, the implementation of SGLT2 inhibitors over time. We see that in terms of quality of life, there was no difference between patients. Of course, quality of life was much better in patients without heart failure. We don't need to say that. But what is usually very interesting, you see this on the right, is that patients with PEF and MREF and REF, they all share a very impaired quality of life. This is very important because very often FPEF is a bit neglected as compared to heart failure with reduced ejection fraction. So the conclusions are that in this contemporary, using a contemporary definition of heart failure, according to, of course, the ESC guidelines and the universal definition of heart failure, where a major focus is on using the HFA PEF score plus high NT-proBNP levels and the ejection fraction. The estimated prevalence of heart failure was actually 16% in the Portuguese population, with a majority explained by FPEF, so 15%. 9 out of 10 patients were unaware of their condition. Prevalence in women was 2.3 times higher than in men. And there is a step increase with age, reaching more around 30% in those with 70 who are older than 70 years old. So these are, I would say, very important data, epidemiological data, to introduce also the innovation that we see in terms of pharmacological and device treatments that we see in the next slides. But if we can add on a little bit more also in terms of, again, of epidemiology. So here we have more focus on outcome and also healthcare expenditure, which is extremely important for the healthcare systems worldwide. That's why the PACT-HF study was particularly relevant in this analysis, which was presented at the Heart Failure Congress. So here we see clinical outcomes at 5 years following an heart failure hospitalization in men and women. We see that the risk of mortality at 5 years is extremely high. It's between 63 and 65% in men and women without no large differences across genders. And we see also that most of patients will die in hospital, and we see that the proportion of patients who will experience a readmission for any reason is approximately 85%. So extremely high risk of outcomes in these patients. And you know that hospitalizations actually are a major explanation for the high costs related to heart failure. Let's talk about costs in this. We see very clearly, here we see costs in Canadian dollars, which is slightly actually lower as compared to American dollars, but you might immediately understand how heart failure is expensive in terms of total cost, readmission, total costs, and this is very much no different between males and females. But if we focus on this side of the slide, although the distribution here in terms of costs for these individual items was similar in men and women, here we see that there are some differences when we add some more granularity to the data, with females more likely to be associated with expenditures when it comes to home care and long-term expenditures, whereas males more likely to be associated with expenditures when it comes to costs in terms of heart failure clinics expenditures and specialist billing costs. So there are some differences in how we spend money related to heart failure in men and women, depending on specific costs. So the conclusions are that most patients were dead or readmitted at 5 years following heart failure hospitalization. The clinical outcomes and overall costs were similar between males and females, although the distribution of costs differed, and costs were greater for specialist invasive care in males, but for females that was higher in for home care and long-term residence. So we add more data regarding epidemiology and costs to what we saw in the Porto study. And whether the epidemiology of heart failure is very burdensome and show that we really need to do something, we have our estimated chairperson has been speaking about the need of implementing GDMT, and actually one of the way we might use one tool we might use for implementing GDMT is to use some ways of monitoring our patients and actually some change in symptom signs and so on may even be triggers to changes in therapies and so on. So let's start with the Telesat heart failure study, which was presented during the Congress. This was a study assessing the association of a comprehensive multidisciplinary remote monitoring procedure for heart failure using an app, which is called the Satilia Cardio, which based the behavior, actually, the monitoring of our patients and physician reaction based on weight and symptom monitoring for our patients, which and reaction of our healthcare professionals happen through a phone-based interface for patients with no or poor digital literacy, whether they could not use the app. And the primary outcome of this intervention was all-cause mortality. So at the moment of medical prescription, patients who were enrolled in the study were registered by the healthcare provider in the Satilia platform. Patients were called within 48 hours by a nurse, which was completing the patient file and explaining a questionnaire, including also quality of life, of course. And then the monitoring happened through the app and via internet or via nurse phone call for those patients who could not use internet and the app. And these questionnaires were about signs, symptoms, and quality of life. So there was a continuous follow-up through the app and by phone and via internet, and algorithm score for 0 to 36 points was used for alerting healthcare professionals about the change in the healthcare status of our patient. The app was, of course, free of charge for the patients, with ensured 100% coverage. And patients with NIA class or higher and NT-proBNP were enrolled in these patients. And the aim was to tailor therapeutics by fostering education every 6 months. And you see here the results in this study. And if you just check to the Kaplan-Meier, I think we don't need to discuss very much. I just want to highlight the RMP group, so the group of patients assigned to the remote monitoring procedure was actually compared to a matched population from France as well, because the study was conducted in France, who actually was not enrolled for this study. So this was not a real randomized control trial, but still a core study, but the treatment and control arm was matched by age, gender, and many other patient characteristics. You see very clearly that there was a 36 lower risk of mortality in patients in the RMP group as compared to the standard of care group. And as I say, the way of follow-up this patient could have been by phone or by the web app. And there was an interaction for the association between the exposure and the outcome, with most benefits seen. Both procedure of follow-up were successful to be associated with a lower risk of all-cause mortality, but the hazard ratio was actually lower in patients who were called at home by the nurses. I might say that probably a person-to-person interaction seems to be still successful in the digital era, but still this study very much highlights how a good follow-up of our patients and any kind of monitoring is actually successful to improve patient care. So the conclusion was that an algorithm-based RMP, based on symptoms and weight monitoring, with personalized frequency and tailored therapeutic education, was associated with lower all-cause mortality compared to standard care within the French healthcare system. This benefit seemed particularly pronounced among digitally literate patients, who often constitute a significant portion of elderly individuals with heart failure at high risk. They were those called by the nurses indeed. And these findings might be, of course, may have implications for clinicians and policy makers. So we had, as I reported, the study on remote monitoring by using digital tools. Let's move to a more, I would say, invasive way of monitoring our patients. This is the proactive heart failure study, which was also presented during the Congress and was instead testing the effect of remote management using seated PEAP measuring. I'm sorry, I'm having a problem with Zoom. With the Cordella PA sensor, in addition to weight, blood pressure, and heart rate on outcomes in heart failure patients. And very important that to understand why this kind of monitoring might be important. It might be important because, of course, by measuring several parameters, and very importantly, for example, blood pressure, weight, and so on, up titration, and actually better management of the diuretic therapy to foster better decongestion might be allowed indeed by having this kind of sensors. But let's see the study. So here, patients with NIA class 3 and symptoms were enrolled. They had a recent heart failure hospitalization and or elevating NT-proBNP. Of course, these are particularly sick patients who might, of course, benefit, might be more important to better follow up these patients because they are at higher risk of outcome. And let's see. This was a single arm study. So, of course, there was no control arm to compare the procedure. The outcome was a 6 months incident of heart failure, hospitalization, or all-cause mortality. So basically, the procedure was tested against the outcome reduction, which was observed in other contemporary heart failure trials, which were testing some monitoring procedure. Here we see basically trials on most of them on CardioMEMS. And we see that the reduction in risk, which was observed in the proactive heart failure trial, was actually very much lower as compared to previous study. And you see also that the procedure was safe. And we see what happened in terms of changes in medications in these patients receiving monitoring. We see difference between the baseline and 6 months. And you see that actually there was not very much in terms of statistically significant results, in terms of implementation of therapies, but what it was very much implemented was the use of loop diuretic. So actually, this procedure really shows how it's possible to achieve successful decongestion, which leads also to better outcome. Of course, there were very strong signal for improvement in dosing and use of GDMT, which were not statistically significant because the trial was not actually powered for that. But we should really appreciate this improvement in GDMT use. So results were that for heart failure patients with NEA class 3 and symptoms, the Cordella system was safe and effective, resulting in low rates of heart failure hospitalization or all-cause mortality, and access to daily PA pressure and vital signs allowed further dose titration, optimization of heart failure pharmacotherapy, and the decreased PA pressure and reduced clinical events are likely driven primarily by increased diuretic dosing, as patients' GDMT in this study was already optimized at baseline. That's why we didn't see a great change over the follow-up. And vital signs assist in painting a comprehensive clinical picture, but clinical decision-making appears to be driven primarily by the PAP. Very important, therefore, to monitor that with this kind of devices. And still, let's try to understand a little bit which kind of weapon we could use in daily clinical practice to improve patient outcomes by improving GDMT use. So we saw very different types of monitoring. We see now a little bit how we could structure our outpatient clinic in order to optimize GDMT. This is the Team HF study. So this was a study which aimed to evaluate the efficacy and safety of a multidisciplinary GDMT clinic within a general cardiology practice relative to matched patients treated with usual care. And we might discuss about that in Sweden, for example, in Karolinska, which is a tertiary center. We have a very similar outpatient clinic to the one which was tested in this study. So here, patients were referred with an echo to this clinic. They had a visit to one, which was in person, together with a multidisciplinary team with a pharmacist, an MD, pharmacist, and all the healthcare providers involved in the heart failure patient care. So there was several titration visits via telemedicine, and the final visit in person, which was at week 12. Indeed, our guidelines say that we should optimize our patient GDMT within actually 3 weeks, 3 months, 12 weeks. 114 patients enrolled. They were matched 2-to-1 to patients who were not considered for this kind of approach. So very intensive approach to the highly specialized kind of clinic. Primary outcome was proportion of patients without contraindications receiving full drug GDMT compared to usual care. Secondary outcome were proportion of patients achieving equal or more than 50% target doses, changes in NEA class in NT-proBNP, and of course important safety and tolerability. And I think these graphs are self-explanatory. So you see that GDMT at the baseline was less than 50%, and after 3 months it was around 45% in patients who underwent treatment through this GDMT clinic. And if we compare these achievements with the control arm, you see that there is a huge difference in terms of the use of all the GDMT as compared to patients who didn't had treatment through the GDMT clinic. So you see there is a huge gap between the red column, which is the GDMT clinic, and the usual care arm of the study. This really shows how probably having a proper follow-up for our patients is the best way to try to achieve GDMT. Other very nice results was that there was great achievement in NEA class in patients, follow-up through the GDMT clinic, reduction in NT-proBNP levels in these patients, and that was very important. A improvement of LVF, reduction in LV dimension, lower LVMI, reduced LAVI, and lower RSSVP. And that's why it's important. It's important because we need to consider that, for example, patients go through screening for more advanced device like ICD and CRT based on LVEF. And therefore, if we implement GDMT, first of all, some patients might not need a CRT or an ICD. And secondly, actually, if we implant a device in a patient and then we optimize therapy only after years, basically, we have implanted the device in a patient who didn't need the device. So very important to consider this point. Indeed, you see here even more clearly that many patients actually jumped from having an AF lower than 35 to more than 35, and actually 27% of patients who had at the baseline an EF less than 50% ended up having an EF more than 50% at the end after the GDMT implementation through the clinic. Also important that the degree of MR significantly decreased over time in patients with going through the GDMT fast implementation process. And this is also important for a referral and placing an indication for TEER, because some patients might not need it whether a GDMT implementation has been successfully performed. So the conclusions are that rapid implementation of GDMT via multidisciplinary clinic embedded within outpatient general cardiology practice was highly effective compared to usual care. The majority of treated patients achieving full drug therapy and receiving equal or more than 40% target dose of GDMT component at completion of clinical follow-ups were very high. Rapid titration of GDMT resulted in improvement in signs, symptoms, SNIA class, and NT-proBNP, and a reduction even in diuretic dose, which I didn't show. And results were similar in those without contraindication for 4 GDMTs. And important that there was an improvement in EF, several echo parameters, and a 50% reduction in the proportion of patients with a 3 to 4 graded MR. So I would say impressive results. And our estimated chairperson has already spoken about the importance of actually GLP-1 receptor agonist in specific phenotypes of patients with heart failure, in particular in obese phenotype, with heart failure with preserved ejection fraction. In this analysis of the STEP-FPF program, which was presented during the Congress, actually the authors wanted to understand whether the treatment effect of the GLP-1 receptor agonist semaglutide was actually consistent or changed or was different across different ranges of loop diuretic use and in patients who were receiving loop diuretic as compared to those who were not receiving loop diuretics. Why did they do that? Just because patients who are obese are actually get different effect, lower effect out of a diuretic therapy. And also diuretics might more affect renal function in this subgroup of patients. Very interesting results were that semaglutide looked even more effective in patients receiving diuretics with a dose effect trend. So you see basically that it was even more effective in those who were receiving higher doses of the diuretics. And this was in terms of quality of life, which was one of the primary outcome of the STEP-FPF program. The effect of semaglutide was consistent in terms of body weight reduction across the different loop diuretic dose use and in patients without diuretics. And same result was in terms of 6-minute walk test, changes, the hierarchical composite endpoint, which was used in the trial, CRP levels, and NT-proBNP levels. You see also that over the follow-up, the changing doses, so patients who were on semaglutide were less likely to reduce their use in diuretics, so they probably needed less diuretics. They were less likely to initiate diuretics where they were not using, and they were more likely to withdraw diuretics whether they were on diuretics at the baseline, whether they were using semaglutide as compared to placebo. So conclusions is that semaglutide 2.4 milligram improved heart failure related symptoms and physical limitation across diuretic use subgroups, and especially these effects were larger in patients receiving loop diuretics at baseline in terms of key CCQ changes, so in terms of quality of life. So semaglutide over 52 weeks of treatment led to a 20% reduction in total daily loop diuretic dose, twofold increase in odds of loop diuretic dose reduction, 66% lower odds of loop diuretic dose increase. So these are very important results, which I think really strongly support the disease-modifying effect of semaglutide in the obesity-related HFpEF phenotype. But there was much more during the Congress in terms of trying to understand how semaglutide might work in patients with heart failure with preserved ejection fraction. And this very important pre-specified analysis of the SELECT trial, and this was called the SELECT heart failure analysis, actually try to understand whether the effect of semaglutide, which were observed in the SELECT trial, were consistent in patients with and without heart failure, and in patients with heart failure across the ejection fraction spectrum. You are very well familiar with this trial. Just want to remind you that it was very large population, and 4,000 patients at baseline in the SELECT trial had heart failure, so large population of patients. And you see here the distribution of HFpEF and HFrEF. Primary outcome of the SELECT, you know, that was a MACE, so composite of cardiovascular death, non-fatal myocardial infarction and stroke. But there was also an heart failure composite, which was heart failure, hospitalization, urgent visit, or cardiovascular death. Other outcomes were cardiovascular death and all-cause death. We don't need to spend time on the baseline characteristics of the populations with PEF and REF, and with and without heart failure, which are just consistent with whatever we have seen till now in epidemiological study. But the results are interesting. It was very clear that the effect of semaglutide was consistent in terms of the MACE outcome in patients with and without heart failure. You see that the P4 interaction was neutral. So this means that the effect shown in the trial was consistent, patients with and without heart failure. And the same was seen for the heart failure outcome. So the reduction in events, in heart failure events, was consistent in patients with and without a history of heart failure. And very important, it's also true that the effect was consistent in terms of MACE outcome in patients with PEF and REF. And it was the same for the heart failure outcome. So the effect of semaglutide was strong in both patients with PEF and REF in reducing heart failure events. It seems the story we have seen with the SGLT2 inhibitors, right? And in terms of all-cause mortality, again, we see consistent results in patients with and without heart failure and in patients with PEF and REF. So consistent results across populations with and without heart failure and PEF and REF within the SELECT population. So once again, we see strong signal about the benefits of using semaglutide in patients with obesity, whether or not have heart failure from the SELECT trial. There was also an observational study on GLP-1 receptor agonists. For sake of time, I won't spend too much time on that. They select in the veteran cohort in US, patients with type 2 diabetes, HFpEF, and obesity. Actually, they ended up having a population which is a little bit strange. They had 3.4% of patients with HFpEF, and being female, which is a little bit unusual to be seen, but the veteran cohort is mainly men, and that's why we see this. They compare GLP-1 receptor agonists with DDP4 and SU as an active comparator, since this was an observational study, and they observed that there was lower risk of all-cause mortality or hospitalization for heart failure in patients receiving GLP-1 receptor agonist as compared to the active comparator. And actually, these studies are very much overlapping with what we study and have already published some weeks ago from the Swedish Heart Failure Registry. This is a study from my group where we used the very rich Swedish registries to compare GLP-1 receptor agonist use versus non-use in patients with diabetes and in patients with diabetes and heart failure. We observed similar relative risk reduction, but when we went to observe patients who were also obese, we saw a very low hazard ratio for the MACE outcome, and which was consistent in patients with FREF, PEF, and MREF, showing once again that in the specific obesity phenotype of patients with heart failure, actually GLP-1 receptor agonists might be strongly beneficial also in improving heart failure outcome. This is consistent with the study from the veteran cohorts. And Miracle trial also was presented, neutral trial, because of limited enrollment of patients. In the Miracle trial, actually this was a global randomized double-blind phase 2 trial evaluating the efficacy and safety of balsirenone together with dapagliflozin as compared to dapagliflozin alone in patients with heart failure and CKD. Important because we know the risk of hyperkalemia is affecting GGMT implementation in patients with heart failure, and balsirenone together with dapagliflozin might be related with lower risk of hyperkalemia in these patients. Primary endpoint was relative change in UACR from baseline to week 12, and secondary endpoints were those response relationship of balsirenone plus dapagliflozin with UACR effect, and of course safety in terms of potassium and eGFR. Patients with FREF, of course, we see that actually balsirenone actually led to trends toward lower UACR levels at the follow-up as compared to placebo plus dapagliflozin. Of course, also balsirenone was combined with dapagliflozin at week 12. Results were not statistically significant because of underpower, since the study was not powered because of the under-enrollment during the study. There were no safety concerns, and actually by using lower doses of balsirenone, levels were not of potassium were not really much increased as compared to placebo. So a very good safety profile in those regards, and also in regards of eGFR reduction. So the conclusions were that actually in this trial there were no significant numerical reduction in UACR with balsirenone plus dapagliflozin as compared to dapagliflozin alone. Hyperkalemia was infrequent, in particular lower balsirenone doses, but further studies are needed because all of these findings were actually not significant because of underpower. Another important study was the RELIEF heart failure trial. This was about intra-arterial shunt in patients with symptomatic heart failure, patients with any LVF. Here it was presented. Sub-analysis where findings were stratified by ejection fraction. The overall trial was neutral, but there were strong differences in the efficacy of this intra-arterial shunt procedure in patients with reduced and preserved ejection fraction. We see here the results. the treatment was strongly beneficial in patients with an LVF less than 40 in terms of reduction of all-cause death, transplantation LVF implantation, risk of hospitalization for heart failure and heart failure events in general. So the procedure, the shunt, was very effective in patients with EF less than 40%, but actually it was harmful in patients with an EF more than 40%. And the results are mainly explained by changes in hemodynamics, which were feasible in patients with HFrEF, but harmful actually in patients with HFpEF. And we see here the results that in the RELIEVE heart failure trial, intra-atrial shunt improved clinical outcomes in heart failure patients with reduced ejection fraction. And there was also a reduction in all types of hospitalization in patients with reduced ejection fraction with the shunt procedure, but opposite effects were observed in those with preserved ejection fraction. And in patients with EF less than 40, the efficacy actually was probably explained by the heart being more compliant at the baseline, and whereas it was not compliant after a EAS, so the shunt procedure in patients with HFpEF, and therefore there was not beneficial effect of the shunt procedure. And I will spend few words on the Budapest CRT upgrade trial. So here we clearly see how CRT upgrade procedure was compared to a no CRT upgrade procedure in patients having an ICD and having an HFrEF, and with RV pacing between 20 and 100%, and being stimulated with a QRS complex more than 100 milliseconds and being on GDMT. This trial very important as compared to previous trials on CRT. There were patients with and without atrial fibrillation. And the overall aim was to show that actually the upgrade to CRT was beneficial in both patients with and without atrial fibrillation. And this was clearly shown in the trial, where upgrade to CRT in this subpopulation of patients highly stimulated by their ICD. Actually, the upgrade to CRT led to much lower risk of the primary outcome of the trial, which was all-cause mortality, first occurrence of heart failure hospitalization, and reduction of LVESV. And this was true in both patients in sinus rhythm and atrial fibrillation, but it's important to highlight that it happened also in patients with atrial fibrillation, where at the moment the recommendation for CRT upgrade is actually lower. And there was also effect in patients with and without heart failure with an upgrade to CRT as compared to staying on ICD in terms of heart failure hospitalization or all-cause mortality, and in improvement in EF, NT-proBNP levels, NIA class. This was true in patients with and without atrial fibrillation. Last study is the Sequoia ACGM trial. This is about aficamten, patients with obstructive hypertrophic cardiomyopathy. These drugs inhibits the cross-link between myosin and actin, leading to some negative inotropic effect, which is particularly important in patients with hypertrophic cardiomyopathy. So they tested patients with the LVOT gradient more than 30 at the baseline, or at following a Valsalva more than 50. NIA class 2-3, and they predicted PVO2 less than 90%. Aficamten was compared to placebo, randomized fashion, some secondary outcomes, but let's go to the primary outcome. So change in PVO2 was the primary outcome, which was very much reduced by an average of 1.74 by aficamten as compared to placebo. And let's remember that each decrease in 1 milliliter on a kilo on minute in PVO2 actually associates with a reduction in 18% of risk of death or transplantations in patients with hypertrophic cardiomyopathy. So very important results. These results were consistent in all the subgroups, in particular in those receiving or not receiving beta blockers, which is at the moment the most used therapy in patients with hypertrophic cardiomyopathy. There was improving in LVOT obstruction during the follow-up. Very importantly, that when the treatment was washed out at the end of the trial, actually the levels went back to the baseline. So important to stay on treatment. Improvement also in terms of NIA class, and also improvement in terms of patients with eligibility to septum reduced therapy. So the Sequoia hypertrophic cardiomyopathy clearly show that aficamten significantly reduced the PVO2 and improved symptoms and in patients with hypertrophic cardiomyopathy. And these benefits disappeared when the treatment was withdrawn at the end of the trial. I'm sorry to have been longer, many findings. Thanks so much for your attention.
Thank you, Dr. Sabrisa, for a very informative and a mesmerizing talk. The first question is, as elaborated by you, we have the STEP-PEF trial, STEP-HFA-DM trial, PRAISE trial, SELECT-HF. All these trials have shown that semaglutide has improved not only the symptomatic part, the quality of life, but also the outcome. So is it right to say semaglutide is also a heart failure drug and it should be included in the list of heart failure? Your viewpoint on this?
That's a very important question. I think at the moment we do have evidence for a specific phenotype of patients, which is the phenotype of patients being obese, actually regardless of whether they have or they have or not diabetes, because we have data on diabetes from the diabetic trials, and we have data regarding no diabetic patients from the very recent trials. So in that phenotype, the treatment is definitely improving heart failure outcomes shown in the SELECT. But at the moment, we still don't know whether there is a future for this drug also in patients without obesity. But we might see. I think what we have been seeing till now, it's extraordinary. So never say no.
But majority of HFpEF patients are obese.
That's very important.
For HFpEF, it should be called a heart failure drug.
In HFpEF, definitely yes. Unfortunately, for
HFpEF obese patients.
Yeah, it's a little bit less, but we have already a lot of GDMT in patients with reduced ejection fraction, right?
So your experience on natriuresis-guided therapy to decrease congestion and acute heart failure, any experience or your viewpoint?
Regarding which
natriuresis-guided therapy.
Yeah. Unfortunately, when it comes to previous trials, all those trials have been, some of them, the small ones, kind of neutral by using anti-proBNP guided therapy to actually guide GDMT implementation and overall treatment with diuretics in patients with heart failure. But some meta-analyses are positive. At the moment, there is no clear evidence. I might say that it might depend on how trials have been designed, but the rationale, I think, is very strong.
Despite advances, the morbidity and mortality of acute heart failure is dismal.
Yeah.
So are there any new drugs in the pipeline which could improve the outcome of acute heart failure in future? Or
regarding natriuresis and
in general, any other drug in the pipeline?
Oh, definitely. I would say we will see what happens with finerenone in the trials, which are like the FINERARTS trials, which are at the moment running. I think what we have seen till now on this drug is extremely promising, and why not? Probably we'll get another GDMT for heart failure with mildly reduced ejection fraction.
Despite the strong HF trial, the team HF trial, the titrate HF trial, suboptimal GMP is rampant across the globe. So what else can be done? What is your DI? All these trials are excellent, but the number of patients receiving GDMT has not dramatically improved. It has improved. So what is your viewpoint? How else we can improve this suboptimality?
I didn't present it now, but there were some baseline characteristics of the titrate HF study also during the Congress. Actually, the use of GDMT was not that bad, but just 1% of the population received 4 GDMT, which is very low. I would also invite our audience to read a paper, a position paper from the Heart Failure Association, which I've been leading and published a few days ago on how to implement GDMT in clinical practice and tackle clinical inertia. I think the overall point is to structure our outpatient clinics in a way that we can guarantee a very well-structured follow-up in these patients. I think that most of drugs do not have any tolerance issue in a majority of the population. So all the underuse we observe is due to clinical inertia. So actually having nurses helping with the follow-up of patients, having pharmacists helping with the follow-up of patients are additional tools that can help physicians for improving GDMT use. This is also what we do actually at the moment in Sweden, where the use of GDMT is quite high.
Why the polypharmacy concept of cancer therapy is not put in heart failure therapy? When a patient suffers from cancer, right from word 0 or right from day 0 is put on polypharmacy. But heart failure, there's still a lot of reluctance to accept the concept of polypharmacy. Why so?
This is our fault, I think, because we have not been enough strong to highlight that cardiovascular disease and heart failure are as deadly as cancer. There has been a great awareness campaign for cancer, but for cardiovascular disease, we are still behind. So that's what we should do. Go to in the squares of our towns, cities, and so on, and speak about heart failure. Because whether the awareness is increased, also politicians will understand that we need to place more resources in research and in the care of patients with heart failure, unfortunately.
Heart failure and CKD are common, and many times we face the problem of hyperkalemia. So it comes in way of optimizing the drug therapy for heart failure. So what is your personal experience with these new potassium binders, Petromar or sodium zirconium cyclosalicylate?
We do have very good experience. Actually, I'm working on setting an implementation clinic in my hospital where actually whether patients following guidelines, whether patients have a potassium level more than 5 and they are not on GDMT, we start K-binder and we give GDMT. As done in the trial, the trials clearly show that K-binders have a very good role as enabler for other GDMTs. And I don't think we really need a trial showing that K-binders lead to lower mortality or morbidity. They increment use of GDMT, and we know that better GDMT use leads to better outcome in our patients. So very simple drugs to be used. Our patients are very tolerant to them. They don't have bad taste as previous K-binders. Low risk of hypokalemia following the treatment, very easy to be used. So we should not forget that this is part of the armamentarium treatments we do have in heart failure.
So how do you look upon inflammation in the context of heart failure? In future, do you expect that these anti-inflammatory therapies, some of the trials are going with IL-6 monoclonal antibody, will be useful in the treatment of heart failure?
Well, I think at the moment we don't have yet great evidence. We have some quite successful phase 1 studies. The development will go on with phase 2 studies. I think that will be really the key to solve also many problems with GDMT. These are therapies which might be probably expensive at the beginning, but actually in the very long term might lead to less issues with compliance, adherence, and definitely better also quality of life of our patients who get less stressed about, you were mentioning, the problems of taking many pills altogether.
There's a lot of talk about the artificial intelligence. I don't know, most of the members of the medical fraternity are not familiar with the techniques of artificial intelligence. So how do you look upon artificial intelligence in medical practice, particularly in the context of heart failure?
Well, AI is very, I would say, already well tested when it comes to facilitate echo measurements, MRI measurements. So in the diagnostic part, I'm actually working a lot on AI as a way to screen for undiagnosed disease in large data sets, like also to prevent outcome in our patients when it comes to heart failure by understanding changes in ACG, small changes in echo parameters and so on. So it might be useful for many things, from easier diagnostic, prevention and prevention of outcomes in patients with heart failure, and also as algorithm to lead to GDMT implementation without the need of having to contact a physician. So basically, kind of AI tool could tell us, well, now you, with this value of creatinine, this value of potassium, now you increase this treatment to that. And this will make our life extremely easier.
So before Mr. Parsati asked me to wrap it up, I have two personal questions for you. First is, what are your 1 or 2 wishes for heart failure?
Well, my biggest wish, and this is what I really focus my research on and my daily activity, is implementation, which we have been discussed till now. So trying to have all of the medical community on board to try to make better. And the second one is actually to try to convince our patients to take drugs, because we didn't discuss that enough. But the second problem is adherence, which is very often quite poor. So these are my 2 best wishes. Try to convince physicians and patients to work together.
What are your future predictions in heart failure?
I think we will see more in FPEF. I think we have now understood that phenotyping is important, because clearly the story on semaglutide shows us that whether you pick the right phenotype within the FPEF population, you might find effective drugs. FPEF is very heterogeneous. We have been lucky with the SGLT2 inhibitors, but they are targeting so many different mechanisms. That's why probably they actually worked in the entire FPEF population. But probably in the future, we might not be so lucky. We should really understand how different phenotypes might benefit on different treatments.
Will mavacamten and aficamten minimize these alcohol septal elevations and surgical myectomy?
I think so. I run a cardiomyopathy patient clinic, and it's difficult to treat patients with hypertrophic cardiomyopathy. They are so symptomatic, and we just don't know what to do. And sometimes, there is just a surgery, alcohol ablation, and nothing else. And sometimes they are not eligible for that. But I think the results of these trials are absolutely great, and improvement in symptoms, it's really what could really have a benefit on the lifestyle of these people who are living their entire life with this disease.
What about the use of aspirin in patients with LVAD? Some newer data has appeared. Is it necessary even with prior vascular disease?
Doesn't seem so. It doesn't seem so, but I mean, I think there will be more data coming out of that.
So I think with this, we wrap up this session, and I think all of us enjoy the flashes of expertise of Dr. Sabrisa, and we hope to meet personally in India. And I'll request Mr. McLeod Pharmaceutical to invite him to India, not for the academic activities, but also for the beautiful sightseeing.
Thank you so much. Thank you.
Thank you so much, Professor Manoria and Professor Savaris, for the wonderful oration and the very wonderful moderation. So both aspects coming out very well. One was the latest updates at the HFA, as well as implementation right at the ground level here in India. We here, as Professor Maria too rightfully said, face a huge challenge with GDMT implementation. Right here, even in HFREF, HFPEF is a different story altogether, as you rightfully said, with SGLT2 inhibitors being the only class 1 GDMT drugs available for HFPEF. So thank you, dear audience, for actually taking up your time. And we are very sure that each and every one of you who has attended the session has ultimately taken your pearls of wisdom to ultimately improve patient care outcomes at each of your centers. Last but not the least, we also thank our technology partners for the smooth streaming of this webinar. And once again, a huge shout out to Professor Manoria and Professor Savaris for the session. Thank you so much.
Good night.
Thank you.
Good night.
Namaste. Good night.
Namaste. Namaste, sir.
Thank you, sir.
Thank you so much.
Thank you so
Bye.
Thank you so much. Thank you so much.
Bye. Bye.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Are we out of
Thank
the recordings?
Thank Kishore.
Recording stopped.
Yes, sir. Stop.